just going to hide back here. I'm just going to hide back here.
Okay, thank you all for coming. Today we have three people from Biota. We have here Anastasia Valley, who is the liaison from Biota to Cathedral Village. We also have Morgan Perotsky, who's very well known to us. Morgan is going to tell us what hospice is and answer some questions. Morgan has a doctorate in physical therapy and is a program director for Biota. And then last but not least, we have Fran Bonjo. Fran is a hospice nurse, and she'll tell us about her experiences as well as telling us all about how a day in a life of a hospice works. So anyway, let's go, Anastasia.
Hi, everyone. Thank you so much for joining us today. I believe that, raise your hand if you were here last year when Morgan and Fran presented on the same topic. No? Okay, awesome. Fresh new crowd. Raise your hand if you've ever sat through a hospice presentation or know about hospice. Okay, great. So I do have a little PowerPoint that we'll go over. I think we will skip some slides just so we can really give Fran, the star of the show, as much time with you as possible because Fran is the one that's actually going to answer real life questions and walk you through real life scenarios. So again, this part will be brief. I will be brief. Just want to tell you a little bit of a personal experience. So I've been with Biota Hospice for about 6 months now. And when going through the interview process, one of the questions that came up was, what is your hospice why? And at first I froze a little, not being prepared for that question. And then actually the answer came to me really quickly and easily. I was blessed to know still blessed to know one of them, but to know both of my grandmothers for a really long time. They raised me when I was little. They were involved. They were there at my wedding. They were there when my kids were born. And there came a day when my oldest grandmother, who ended up passing away when she was 98, just kind of, luckily she didn't have many chronic illnesses, but she just wasn't her usual bubbly self. And we all saw it. And of course, my mom, who she lived with, she got really, really scared. I, having worked in hospice before, realized that it's just kind of a natural part of life, right? She was sleeping a lot more. Before she was super excited about getting up and getting dressed in the morning. And in fact, if she saw me in this dress, she would probably ask my mom to go get her the same one because she always wanted to dress like me. She used to always have a really big appetite, wanted to try delicious foods throughout the day, and that just wasn't the case anymore. And it just started progressing more and more. And my mom, she had this first urge to say, okay, let's get grandma to the hospital. Let's see kind of what's going on. And then I had a conversation about hospice with her. And being from Eastern Europe, I was born there, and obviously so were my parents and grandparents. The word hospice was a very scary word. And mom was like, no, we don't need hospice. I'm like, Mom, let me educate you a little more about what hospice means. Hospice does not mean that, grandma is here today and gone tomorrow. Hospice is just a service that grandma can receive to make sure that her quality of life, for however long that is, right? Because only God knows how much time we truly have, but her quality of life is enhanced. And she can have some medical supervision as she goes through the next, few months or again, however long she's on services. Long story short, I was able to convince my mom, who is still eternally grateful for having the opportunity to have my grandmother on hospice, because anytime that there was a medical change within her condition, she could call this hospice nurse. The hospice nurse would come out or call my mom just to walk her through what is normal, what to expect, what is not. She had a wonderful social worker who not only helped my grandmother through the process, but also was there for my mom. And at the same time, my grandmother never had to be in a hospital full of needles and probes to figure out, what is going on, when we all kind of really knew the answer. This was just, this was her, where her life cycle kind of was coming to an end. So that was my hospice why. And after seeing my grandmother go through the hospice benefit, I truly kind of connected to it much more than just talking about it. So that's just a little personal story, but let's get into this. So how does actually hospice help? So this quote says, "You matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die." There's a brief history of hospice, unless that someone really, really wants to. I wasn't going to walk through it because it's quite long, but just to kind of, you see some numbers on there. It's hospice is a relatively new thing as a benefit, as a part of the services that the medical world provides. And today, or in 2018, I'm sorry, there were 1.5 million Americans serviced by hospice. But if you compare that to the number of people who passed away without hospice, it just shows that we have a lot more work to do in educating of what hospice truly is and what hospice could do. So this just kind of shows you the overlap between between curative measures or therapies, and then how they overlap. Oh, sorry, that didn't. Yeah, it's not switching.
It's not moving. It's not moving up there. It's moving on here.
That's weird.
Do you need to see?
You lost focus. I mean, go ahead, you do it.
Let's exit out of here first. Go back. This just isn't going into.
It's fine.
Yeah, it's,
There you go. Awesome. So this was actually the slide that I was describing. On the left you see the curative measures, and so I described the case with my grandmother, who was just she didn't really have any diseases, right, that we were monitoring. So a lot of these things didn't apply to her. But a lot of times, most times, I'm sure Fran can share more. Hospice is initiated or comes into play when a person does have a disease, or that they're no longer seeking treatment for, or treatment is no longer effective for. So then, you can go over to palliative care, and then, of course, hospice care. And that's just kind of the disease progression. And then all hospice care is palliative care, but not all palliative care is hospice care. So what is hospice? Hospice is a process. It's a concept of care, the goal of which is to help a person optimize their quality of life and dignity until he or she passes away. Hospice exists to provide support and care for eligible patients and their families, enabling them to live as fully and comfortably as possible. Hospital recognizes dying as a normal process, and hospice also affirms life and neither hastens or postpones death, which I think is also a common misconception. I know it certainly was for my mom when I was trying to get her on board. Hospice eligibility. So a person is eligible for hospice care through the Medicare hospice benefit when they're eligible for Medicare Part A, and their doctor and the hospice medical director certify that they have a life-limiting illness and death may be expected in 6 months or less if the illness runs its normal course. That does not mean that if a person lives past 6 months that they're kicked off of hospice. As long as they're still clinically eligible, they remain receiving the hospice benefit because, like I said earlier, only God knows when it's truly our time.
Sorry, guys. I'm so sorry.
No worries. And then once an individual meets the eligibility requirements for hospice, he or she has to agree to election of hospice, which means that they forego aggressive and curative treatments in exchange for this palliative care. They receive hospice benefits in periods of 60, or 90 days. And again, it renews as long as they're still hospice eligible. And the hospice care plan is patient-driven, including the election of their hospice benefit. So even if you elect hospice, you can technically opt out of it. If for some reason the hospice idea is no longer appeals to you. Patients may resume curative goals if their plans for palliative care change. So this is just kind of an overview of what hospice can provide. Again, it is a service that's available 24/7. There are some medications that are available for pain management and symptom management. Supplies are provided as needed, such as a hospital bed and all the way to personal care items. And then, of course, the team. Right. So again, another misconception my mom had is that hospice is strictly comprised of a medical team. You have a nurse and that's really it. But it's so much more than that. There are spiritual counselors, there are social workers, there are personal care aides, bereavement counselors, and so on. So it's really quite a interactive, multidisciplinary approach. So again, some of the people who fit into this are bereavement support coordinators, volunteers. We actually at Viata have a really great volunteer program. We offer things such as pet therapy, music therapy. We have a very strong veterans program, and we do a lot of really great things like veteran pinnings. If any residents here are veterans. Of course, pharmacists who oversee the medication, hospice aides for personal care, nurses. Of course, we have a medical director and a physician team to oversee everything. Therapists as needed, social workers, and spiritual counselors. So the basic hospice team functions is that we assume responsibility for the patient and the family, complete initial comprehensive assessment, identify patient and family expectations and needs, develop a plan of care, provide visits and respond to on-call needs, review and update care plans as expectations and needs change, and continually manage interventions and outcomes. And of course, later on, provide bereavement support. I'll skip this because we're really talking about somewhere kind of in the middle of here, and respite care probably is not relevant. So
yeah, and that confuses them with those 4 levels.
Yeah, of course. So I think I don't know if Morgan has something that you wanted to say, or we can jump straight to Fran.
We can jump to Fran.
Okay.
Yeah, for the
Okay, here
the
I
first
come.
part.
Why don't is there part of this that you were going to do, or?
No. Anastasia was speaking on the hospice
Mhm.
part.
Does anyone have any questions regarding just kind of the general overview of what hospice is before we dive into the real world and real life scenarios? No? Okay.
Go for it.
All right.
Okay.
Thank you.
Do I need to wear the headpiece?
Fran? Oh, she has.
Do I need to wear the headpiece or should I use the mic? No one either?
over the back of your head, yeah.
How's that?
Now you're official. Perfect.
Oh God, I feel so important with this thing on. I probably look like with this hair sticking out. So my name's Fran, and I am a registered nurse, and I am a hospice nurse. I started here about 4.5 years ago. Started out as an RN case manager, went out in the field and saw a lot of people. I also was the admission nurse, and I did all admissions all over the place. We have Chester County, Delaware County, and Philadelphia County that we serve. And then I went into the office as a clinical manager. Right now, I'm in a hybrid of in office, and sometimes I go out and sometimes I do this. So, but I've been asked to give you a scenario of what my day might look like if I was out in the field. So usually your day starts with a morning meeting, and then you start calling your patients and scheduling your visits for the day. So anybody that you would have on your caseload, you would call them and see what's a good time to come and visit. So once you get to the visit, once I would get to the visit, you go in there, and I usually talk to them for a while, talk to the family. We take your vital signs. If you have anything that we need to take care of as far as wounds, incontinence care, or anything like that, we can do that while we're there. Then we talk to the family some more, and we decide whether or not we need to make any changes in your care, depending on what's going on with you at the time. And that's pretty much how it goes all day long. We do have home health aides that can come out like 2-3 times a week. They come out, they can do bathing, they can get you up, feed you meals if you want meals being fed, give you a shower, whatever you would need at the time. Social work comes out also. And like she said, everybody's assigned an RN, social worker, spiritual counselor. We have volunteers that can come out and sit with you. We also have a music therapist that comes out and can play music. And I think that is like the most of my day when I'm out in the field. And inside the office, it's a different story. Also, when you're out there in the field, everybody's calling you. So the family members, you can call all day long, no matter what. Even if you call the number and you go in and you get into the office, they will send you to your case manager. We can manage your meds, anything that is related to the admitting diagnosis of being on hospice is covered from the Medicare hospice benefit. And you guys all receive the Medicare hospice benefits once you get onto Medicare. And you guys chime in if I'm doing something. So that is that part. When someone is being admitted, we go over the clinicals, we get an order for the admission, and then we send out a nurse to evaluate the person. And we got people up there.
I was just gonna later, if everyone wants to play this little clip, it's a 3-minute clip. It just explains. Okay, so we talked about through all of this, but how do we know, right? How do you know when someone is eligible?
Sorry, so how do you know when someone is eligible for hospice, or it might be time to have the hospice conversation? Do you want me to play this clip and see?
I can.
Or you can just
Walk.
Yeah, that's we usually get referrals from physicians, from your doctor, or we just get people calling in saying, I have this person and I'm trying to find out information about hospice. So we tell them what we do and what we can provide to them. And then once we get clinicals and review, we can go out and evaluate the person. And 9 times out of 10, they do get admitted. And that was when I used to do admissions, that was my first question: why hospice and why now? And we need to know what's going on, and we need to make sure that whomever is admitting the patient, or if the patient themselves are doing it, they fully understand what they're getting into. Do you have any questions so far?
I do have a question.
Go ahead.
All these extras, like an aid to come out and all that, is that included, or
Mhm.
those extra
Yep.
charges?
It's all part of it. It's all part of the hospice benefit. We also supply incontinence supplies, bathing supplies. It's also the DME is included, which is like your wheelchair. If you need a hospital bed, we can do that. If you need a walker, we can do that. And oxygen, we always send oxygen into the home right from the start. So we do all that. I lost my train of thought. Let's see, where was I at? Admissions. Okay. So once we get you all admitted and we evaluate you, we take what we call like the baseline of what you are like at that point. And then we go over your meds. Any meds that are related to your diagnosis will be covered under hospice. We have a pharmacy that we use, or we can use your own pharmacy, whatever you'd like to do. When you come on board, we get approval from our medical director, and he can either follow you as the primary care physician, or you can keep your own primary care physician. And 9 times out of 10, people keep their own, or sometimes the primary care physician will say, let the medical director do it, but just keep me updated. So we just keep them updated because sometimes meds get changed very quickly, especially when you're coming towards the end of where you need to be, and we change medication dosages very quickly. So that's much easier to do through our medical director. And I think like the PCPs kind of don't want to play with those medications. So we can do all that. And what else? I think that's it.
Do you want to kind of go over this slide about kind of what the progression?
What does Bayada do that's unique?
I knew that was coming.
What does Bayada do that is unique with regards to their hospice care? A lot of the things you've mentioned so far are pretty much what all hospices do, correct?
Right.
Yeah.
Sure.
You guys can hear me? Okay. So that's a good question. How are we different from other hospice agencies? It really depends on the patient, the resident, what your choice is. So we can say that we provide the same 5 days aids a week. Everything is covered, but it's really about the care that you're receiving. So here you're speaking with Fran, who is a nurse that you would see as a hospice, if you're on a hospice episode. We also really focus on the bereavement after you pass. So the bereavement period it's a year, right?
13 months.
13 months, so more than a year. We focus on that bereavement period for your family. We provide that extra layer of support for your family as well. Do you want to talk a little bit about what we
about the bereavement?
Mm-hmm.
They call you with updates. We also have a little program that's called the Bear Program. I don't know if you saw that or not. Is where whomever the person is that passed, the volunteers will take whatever clothes or shirts you want to give them and make little memory bears out of them. We are. Go ahead, you finish. I just lost my train of thought again. I'm sorry.
I can chime in for one other thing that I really like to share.
It's been about 34 years since Bayada has become a nonprofit. So Bayada is one of the largest agencies, one of the oldest agencies in the Philadelphia region. So there are over 50 years of reputation that you can count on, right? We're not an agency that came about yesterday and who knows where we'll be in a few years. We have all service lines. So before you get to hospice, we do provide the home health and other services. So there is that continuum of care that we offer that maybe other hospice agencies do not. But back to this nonprofit piece, that was really important for me when deciding to go with Bayada, because that means that whatever money that the agency is making, it's reinvesting right back into the care, into different technologies. We have this program, and this is more for providers, but that tracks through like AI, and it's way over my head, but kind of the progression of disease. And it can trigger us in the office to say, you know what? We should see this patient now, not once a week, but once a day. So I think that's a really important differentiating factor for Bayada.
I know in today's world and environment, speaking about AI and what companies are doing with AI is a little touch and go a little bit.
Yeah.
But Beata in general, for all service lines, we really have been focusing on AI and how it can help with not just decision making, because we can make that decision, but also if an insurance company wants to cut visits, or an insurance company says, well, based on this, they're not necessarily hospice appropriate anymore. So we can go back with that information and say, no, they really are, and it helps that fight, because that is something that we see across service lines, insurance becoming more nitpicky, which is not fair to you guys.
And other hospitals, oh, sorry, go ahead.
She wants to go next. Oh, go ahead. Go ahead.
I would like to know if a patient is in pain and if this person, like my partner, was very much, he was in pain and needed to be moved around to reduce that pain. And so is there someone there all the time? The hospice nurses only come just for a visit. What about a total care for a patient from morning till night?
Right, and that would be something that the family would have to provide. We do send our nurses out. That seems like when they get to that point where they're in so much pain, our nurses will come out every day and we can get the aides out there. We are available 24/7, and when you call us after hours, we have a nighttime runner that's there all night long until the morning, until we come on again. And that the people that you're calling into are Beata Hospice employees. It's not like an agency that we go out and get. So that's how we handle that. But lots of time families do need that, and we do the best we can to try to help with that. I know, like, one of our social workers just the other day, the person had to go out and do something, so she went and sat with them for a few hours. It's called a respite stay, which is something completely different than this respite stay that when you go into a facility. So we try to make arrangements for whatever we can. We help you try to find an agency, like Beata has an assistive care office, which is that's what they do. They send out an aide for so many hours a day.
So the question I have is, does it matter to the patient whether the hospice is for-profit or non-profit?
I was going to touch on that because he said every hospice is the same. That depends. No. When hospices are for-profit, I know because I have come in on the admission of someone coming off of another hospice for the reason that they will limit you to what supplies you can have. Like you can't have this, or you can only have one pack of that, or you can only have either or, whereas we don't do that because we're nonprofit. Whatever you need, we give you. If we don't say, no, you took too many wipes, or no, you have too many briefs, or too many pull-ups, or you can't have this equipment, or you can't have that equipment. We don't do that. We get you whatever you need.
Does it matter if you're at home or in Bishop White, for example?
You can be at home. That's kind of like some of the differences where those levels she was showing you. You know, first the levels is where the decline comes, and then everybody recognizes that we may want to go down this road. So either the primary care physician or whatever physician is taking care of you will make a reference to us, and then we come out and evaluate, and we can admit you as a home patient. Some patients, when they have a disease that they're very, very, very in a lot of pain, or they've got a lot going on, and we can't do that. We can't help them while they're out there because they need pain control via IV or something else. That's when you go to what we call general inpatient, and that's for any place that has a general inpatient where you would stay at the hospital on a hospice service. And then the other one is a respite, and that's for basically for your family members. If somebody's taking care of you and they really need a break, or they need to go on vacation and you can't go, we arrange for what we call a respite stay at a facility so that they can go and stay there. Medicare benefit will pay for 5 days at a facility to stay there while your family goes away or does whatever they need to do. And we can do a respite stay for 1 day up to 5 days. Some family members will do it longer and then just pay out of pocket after the 5 days.
I have a question.
Yes.
Would you clarify? It says there.
No, you got to keep it right up to your mouth.
It says a hospice consult can begin when someone is experiencing any of the symptoms, how does that tie into everything we keep hearing that the hospice is when somebody has 6 months to live? It's like two sides of a coin, and I'm not sure how they meld.
But usually, if somebody's in the hospital, what they'll do is they'll send in their own, what they call hospice or palliative team. And they'll talk to the family and they'll explain about what hospice is. And the doctor usually asks for that if that's the road that he wants to go down. And that's where that part comes in. Family-wise, when you're out in the community and you're not in the hospital and you just want to come on, or somebody in the family calls and says, we want to talk to you about hospice, we do that evaluation when we go out. And when the nurse comes out and evaluates the person, that's either they are admitted or they're not admitted. We have seen people that we've evaluated and we knew we're not ready for hospice. So we did not admit them. Same token, when you're on hospice, it's not necessarily 6 months, even though it is 6 months, it's kind of hard to say. We reevaluate you after so many days, and they're called certification periods. So after the first 90, you'll get recertified. As long as there's some little bit of a decline or something else going on, or depending on your diagnosis, you'll get recertified again. We've had people on services for over a year, depending on what their diagnosis is. So it's not necessarily that you're going to come off in 6 months. We've had people, like now, they get better. So we discharge them. So we're in the process of doing that now. So it's not that once you get on hospice, that's it, you're done. You have the ability to revoke. I've admitted patients that called the very next day and have revoked. They didn't want to be on hospice, they changed their mind. So we just do that. We just let them discharge them.
How are the costs covered? Is it Medicare?
Medicare.
Or everything is Medicare, even for even for these situations? Okay, thank you.
I just want to add one thing there. You mentioned, it's a decision when you have 6 months to live. That's not the decision that you internally or your family will know when you're ready. When you feel like you don't want to treat whatever chronic diagnosis you have anymore. There's a lot of factors that go into it. But yes, people do graduate.
Yeah, we've been doing that a lot lately, because sometimes people come out of the hospital and they were so sick in the hospital and they look like, oh my gosh, so we put them on hospice, and then 3 months down the road, they're starting to perk up again, they're starting to eat again. So then because we evaluate you every so many days to recertify you, that's when we decide, okay, this person really doesn't need hospice right now, so we just talk to you, we set you up with whatever equipment that you need or whatever supplies you need for a couple weeks and meds, and then we discharge. So then you're on your own. But if you ever want to come back, we've done that too. We've discharged people and then we've taken them back on in like a few months because they've gone back down to where they were to begin with.
Yeah, and also adding one more thing to that too is what makes us a little different is the continuum of care that we talked about. So if you do graduate from hospice, you always have the opportunity to flip to a home health episode where you'll get that progressive nursing, PT, OT, speech therapy, in order to continue to meet new goals that you might have, because you're now getting better, quote unquote, on paper. So maybe you have goals to, maybe I want to start walking around outside, or maybe I want to gain some strength, gain my balance. So there's always that opportunity too, and it's essentially the same team. It's myself that says the same between the two, hospice and home health, but our teams are in communication the entire way.
You mentioned that a person can keep get their meds from their own pharmacy or
Yes.
Biotis. However, if you're in hospice, you don't get any meds. Is that right? Except
No,
for
you
pain
do.
control?
People continue to take their regular medications for a very long time while they're on hospice. We only stop medications like you're talking is when you get to the point where you can no longer swallow them, or you just won't take them, depending on what the disease process is. But people do stay on their medications, yes.
And if you're a patient in skilled nursing, how does
what layer is hospice?
That would still be kind of considered a home hospice. It's a little tricky with skilled facilities because the skilled facilities we need to have a contract with, and if they won't contract with us, we can't do anything even though we try to. And basically it's the same as a home patient. We go in a couple times a week, the nurse goes in, assesses, does vital signs, checks on the meds, talks to the nursing staff to see how you're doing, and we even send aides into that atmosphere also, so they're in addition to whatever help they have there already. It's in addition to that. So it's kind of like the same thing as a home patient.
In your experience here at Cathedral Village, have you done hospice in the skilled nursing as well as in people's apartments?
I don't think we have any skilled ones here. Do we have a skilled one here?
I don't think
we do.
No, I don't think we do right now. I think we have patients on other hospice groups.
Yeah.
That's a very long one.
I got it.
Okay.
You want this? You can have head thing.
So you actually asked some good questions. Maybe I can give you some color on some of those questions. So when you're in long-term care, if we start noticing any of these things, right? If we start noticing a gradual decline or progressive decline, or we notice that you're going to the hospital more, or, we're seeing that the patient isn't moving much, they're having, skin decline, they're getting wounds, at that point, we try to communicate with you and obviously the patient's family to figure out, hey, this patient's not doing well. It's time for this patient to maybe consider hospice or palliative care. And at that point, you're obviously in long-term care. You can continue to stay in long-term care.
Yeah.
And we would have, one of our social workers involved, and they would present you with the choice of hospices. And even if they didn't have a contract, for example, with Beata, like if Cathedral Village didn't have a contract, they can still do a one-time contract and have
for that patient.
Beata, for that patient to have Beata, see that patient. One of the things, I had Beata at my other building at Paul's Run. One of the things I like about Beata is that continuum of care. That's what I was actually talking about. A lot of the patients, they have, Beata is actually a very big therapy company. They do a lot of good PT, OT, and that actually provides good continuum of care because they actually start noticing if patients are starting to have that decline at home. And actually, they provide us with that information, and with other information, we can kind of determine that, hey, this patient's really declining. There's things going on. They're not doing well medically, and then we can say, okay, well, how do we keep this care going and still provide them with palliative and hospice care? Mm-hmm. And then Beata, for example, a company like Beata can step in and say, hey, we know Mrs. Jones, and we would like to continue to take care of her. And they step in, and sometimes it's the same people, that are caring. Like I think we have John there, right? And I see John all the time. And a lot of these patients already know, they're familiar with the nurses there. The other cool thing about Beata, is their therapy, right? You could continue to provide a little bit of therapy services while in hospice.
Yeah, so we can contract with ourselves. It's
really cool.
So it's all contracts in healthcare. But we contract with ourselves, and it's if, say, you need some assistance with getting in and out of your new wheelchair that you got with your hospice episode, or your hospital bed. So you can continue to receive it, but I do want to make it kind of clear it's not the same type of frequency that you would get if you weren't on hospice.
Yeah, it's only like a couple of visits to kind of teach you what to do, but the therapy can do that.
Or speech therapy too.
Or teach your family how to do it. Say they don't know how to transfer you to get you out of bed and into a wheelchair. We can set up a couple of therapy sessions with the physical therapist or the occupational therapist to show you how to do certain things or whatever you need at that point. And we do. Speech can come out and kind of peek at you too if you have a hard time swallowing, and they can look at that and then make recommendations. Do we need to put somebody on a soft diet or... puree diet, or is it time that we should stop eating? What are we doing?
Right.
So, and they kind of give us that information.
Right, like if they're having a hard time swallowing pills, what are we doing? I mean, I think that's actually very helpful. In addition to the hospice care we guys provide. In terms of medications, when we start hospice care, we take a comprehensive look at all of your medications. For example, if you've been on, for example, a statin drug, well, that statin drug might not be really providing you any additional benefit. That's a more of a long-term medication that you're taking to prevent your arteries from clogging up, which they might already be clogged up. So we would determine, is this medication beneficial or not beneficial? And we would discuss, all right, let's stop this medication. Obviously, something, for example, like say you're on Lexapro for depression, we might continue that medication because it continues to help your mood. So every medication, it goes on a case-by-case basis to see, is this helping, this person, enjoy that quality of life? It all comes back to quality of life. If something is enhancing someone's quality of life, we will continue to do that in hospice, under hospice care. Is that correct, Morgan?
Yeah. And even if okay, here we go. Can you hear me? No?
Not very well.
She took this thing off.
Back on the head.
No, I know. I didn't take it off my head.
Why don't you take that?
Good idea. Sorry.
But just to the question of can we keep our own meds, some people and their families don't want to stop any meds, and it's still okay to stay on those meds, like even the statins and things like that. They may not be doing very much, but it's the comfort of the patient who wants to take those meds because they've been used to taking those meds, and the family wants to make sure they're still taking them. So if that were the case, even though it was something like a statin, we would still keep you on those medications.
It's a conversation.
Yeah.
Every single thing is a conversation. If we feel, or if the family feels, or if the patient feels that it's going to enhance their quality of life or their well-being, we'll continue that, or we'll add that service. So I think it's important, and those are actually very good questions.
I actually have a question. If we're talking about medications, diuretics, would that be one that you typically discontinue or continue?
So it would depend. So if a patient
Everyone loves their diuretics.
I know.
And I would say this: if someone has heart failure, right, and they've had multiple CHF exacerbations in the past, and that diuretic is keeping them from getting flooded again, especially their lungs, I would probably continue that diuretic.
Yeah.
Same goes with blood pressure medications, right? Let's say someone has had a stroke in the past, okay? Now, controlling your blood pressure is very important if you've had a stroke in the past. I would probably make sure we try to prevent another stroke while you're on hospice care, because having a stroke is not very comfortable. And so these are the things that we're looking at. It's about enhancing your quality of life, and anything that will do that, for example, preventing you from flooding in your own lungs, having another CHF exacerbation, or preventing a stroke, we're going to continue that.
I was just curious.
Yes, I would probably keep it.
But they're pretty good points. That's what we do.
Those are good
Does
questions.
anybody have any other questions?
So you always differentiate palliative care and hospice care. They're not exactly equivalent. So how much palliative care do you do without putting a patient in hospice?
So you can do a lot of good palliative care without putting someone in hospice. I mean, you can say, for example, let's talk about something simple as lab draws, right? You have a patient who's 98 years old. They don't want any additional blood work done. Poking them every day is not enhancing their quality of life. We'll stop doing that, right?
Right.
So there are multiple things you can do to enhance someone's comfort. That's one of the things you could do.
And palliative care also sometimes includes more rigorous therapies.
Right.
Yeah, I'm sorry. So I usually give an example of somebody that's on dialysis. they don't know which way to go, whether they want to be on palliative or whether they want to be on hospice. And one of the important questions that we ask is, do you want to continue dialysis? On palliative care, they can do that. We cannot do that on hospice. Same thing with the blood draws. We would only draw blood on hospice if we needed to somehow get labs on you to qualify you to stay on the service. So it's things like that, like the aggressive treatments that keep you maintained where you are, you can do on palliative, but you can't do on hospice. Does that make it clear as mud?
Yes. So if a patient's in our skilled nursing and they go into hospice, do you, doctor, make the decision on whether to stop the statin, or does hospice?
So we work with the patient and their family, and obviously the hospice care team as well, because not only am I saying that this patient is hospice appropriate, we have their hospice medical director also saying that patient is hospice appropriate. CMS has a very strict set of guidelines that you have to meet to be hospice appropriate. If you go on their website, those rules are actually, they're very specific.
Yeah.
And they're up there, and they follow them actually very closely. And they have to. So once that happens, your hospice care team usually hands us a list of the orders. Sometimes I've gotten orders from the hospice team saying, let's discontinue this, let's do this, let's do this, let's start them on morphine, let's start them on Ativan. And then we kind of discuss it, and usually the hospice care team discusses it directly with the family at that point. Hey, this is what we're going to do. Right. So, and then that could be a conversation as well. I mean, between all of us.
Is it clear who's in charge? You or the medical director?
Do you want me to answer that?
Yeah.
It's if you choose your primary care physician to be your care physician, then that person would be the first person. That's the person that's going to direct care. We go through. But if we have our medical director and you didn't want your primary care physician, we would go to our medical director. So it's all depending on who you want to keep as your physician.
Thank you.
Okay?
Yeah.
Works for you.
It doesn't have to be a one-sided decision. It's a conversation. I think that's what we're all trying to say. It's a conversation.
Sorry.
It doesn't have to be one person deciding that you're not going to be on this medication. We can all have a conversation whether we all believe that this is helpful or not helpful.
Yeah. And even if you don't want your primary care physician, we still call them and let them know what's going on. Even if our doctor is following you, we still call them and kind of give them an update on what's going on. This is what we're doing, just so that they keep updated.
I know a lot of you have had the same doctor for 30, 40, 50 years, so they appreciate that as well.
Okay, are there any more questions?
We have a sleeper. That's all right. Let him sleep.
Does anyone else from the Wellness Center have anything that they want to speak about? Yeah.
Qualify for Medicare? Does other insurance cover?
We do use Medicaid.
Medicaid.
And personal, if you have like a personal insurance of some sort, yes. Yes, if you have like a personal insurance and you're not on Medicare, we can use that. We have to make sure they agree to it, so that's the insurance company. And then we do Medicaid. Oh, I'm sorry, you're up there.
Yeah, I was just going to say that all insurance plans have a hospice benefit.
Right.
It's just if you also have Medicare, it just goes on to attaches to Medicare. But
one question I had actually, The respite care.
Mhm.
Can you explain more about the respite care and how
About
does
what-
someone qualify for that and where can they go?
Everybody is entitled.
If you're on hospice, you're all entitled of respite care if you need it, if somebody would need it in the family. And basically, we contract with certain facilities, and we also talk to the family and see where they think they might want to put their loved one for a few days while they have and go and do whatever they need to do. So that's how that process starts. And then we just work up a respite contract, and then we do that with the facility, and then you can go to the facility and stay there. And that's all covered under the Medicare benefit, under the respite part. And anybody can have a respite. You can have it for 5 days. It also can be redone, I think, once every certified period, if I'm not mistaken. So it's not just 5 days and that's it. It's like when you get into your next certification period, you'll get another 5 days if you need it.
Make sense? Is that what
That's-
you needed?
Yeah, I know about it. I just want them to have that information.
You're testing me.
No, I think it's important that everyone has the information that they need.
Yeah.
So clarity is important.
Is there anything else? Okay, let's
Oh,
thank the
okay,
people.
another
We have one more?
One more, so does that mean if someone is in hospice in their apartment here at Cathedral Village and their partner needs a break, that you would arrange for the patient to go into our skilled nursing?
Yeah, that would, if your skilled nursing wanted to take you for a respite for 5 days, yes, we can work that out.
Whom have you used in the area for respite?
Jesus, I don't even know who we have.
We use a lot of different places because we get like one-time contracts, so we just try to go to wherever the families want. And most of the time they want it near where they're living, so we'll have to look for a place there. It's like a whole process we have to go
Usually
through to
it's the
find.
family asking if they can go there, and then facilitating that with that facility, if they can do the one-time contract type deal.
Thank you.
Anybody else?
Okay. Okay, thank
Good,
you all
thanks.
so much.
Glad to be here. You got the